Hello everyone. Today I'll be talking about pneumonia, empyema, lung abscess, and towards the end a short note on aspiration pneumonia. Starting with the types of pneumonia, there is community acquired and nosocomial pneumonia. Nosocomial pneumonia can be further divided into hospital acquired pneumonia, which is got 48 more than equal to 48 hours after hospital admission, and ventilator associated pneumonia, which occurs more than 48 hours after intubation. So what are the causative factors for pneumonia? So coming to community acquired pneumonia, the most common organism is Streptococcus pneumoniae. Then comes Haemophilus influenzae, especially in patients with COPD and in smokers. Moraxella catarrhalis. Staphylococcus aureus is an important cause of post-influenza pneumonia. Klebsiella is especially seen in patients with aspiration, abscess, and alcoholics. So you can think of the 3 A's. And finally, Legionella is a cause of atypical pneumonia that causes pneumonia especially in patients with COPD, smokers, and immunosuppressed patients. The organisms that cause pneumonia in immunocompromised patients include tuberculosis, fungi like Aspergillus, and Pneumocystis jirovecii. Hospital-acquired pneumonia is specifically caused by organisms like Pseudomonas aeruginosa and methicillin-resistant Staph aureus. Now, there are pathogens that are based on the specific etiology. Like, for example, alcoholism is associated with organisms like Streptococcus pneumoniae and Klebsiella. COPD and smokers have pneumonia due to Haemophilus influenzae, Streptococcus pneumoniae, Moraxella catarrhalis, and Pseudomonas. And these organisms also cause COPD exacerbation. Aspiration pneumonia occurs due to oral anaerobes, gram-negative enteric flora like Klebsiella. Lung abscesses are associated with oral anaerobes. HIV infection or immunocompromised conditions are associated with Streptococcus, Pneumocystis, Histoplasma, and Aspergillus. Now, this is important. A hotel or a cruise ship, if it's mentioned in the question, you have to think about Legionella. Exposure to bat or bird droppings associated with Histoplasma capsulatum. Exposure to birds is associated with Chlamydia psittaci that causes atypical pneumonia. And exposure to farm animals is associated with Coxiella burnetii, which causes Q fever associated with headache, hepatitis, fever. Now, coming to the clinical features and examination for suspicious pneumonia, the patient comes with cough, dyspnea, pleuritic chest pain, systemic features like fever, chills, fatigue, malaise. On examination, you will find tachypnea, increased work of breathing, increased tactile fremitus, and dullness to percussion because you have a solid-like consolidation that is present between the lung and the chest wall. So you get a dull percussion sound. And on auscultation, you can hear crackles, bronchial breath sounds, egophony, and whispering pectoralochi. All of these are characteristics of a consolidation. Now, coming to imaging, the imaging of choice is a chest x-ray, and you can find one of these 3. You could find lobar consolidations, infiltrates, or cavitations. In fact, you find in atypical pneumonia, it's more likely that you find infiltrations. Lobar consolidations are usually found in lobar pneumonia. And to make a diagnosis of pneumonia, you require the clinical features that I mentioned previously, along with the demonstration of either an infiltrate or a consolidation or a cavitation on chest x-ray. Now, note, in some patients there may be a need to do a further study like a CT scan if the initial x-ray is negative. These kind of patients are immunocompromised people, like people on steroids, HIV, tuberculosis. These people may not have an infiltrate on X-ray because of inadequate cytokine response and inflammatory cell recruitment to the site of infection. So otherwise, in another patient, chest X-ray is enough. Also, there is less utility of obtaining blood cultures and sputum cultures. So we basically go by clinical features and radiographic findings. Now, once that is done, the next step in management depends on severity score. Now, there are many scores, but in this video, I will be focusing on the CURB 65 score. CURB 65 score, the C stands for confusion. U is uremia, that is more than 20 milligram per deciliter, more than 7 millimoles. A respiratory rate more than 30 per minute. Systolic blood pressure less than 90 or diastolic blood pressure less than 60 millimeter mercury, and an age of more than 65. Now all these criteria have a point each, and you'll add up all the points to further manage the patient. So based on the score, you can decide the site of care. Where will you be treating the patient? So the first option is an outpatient management or ambulatory care, where the CURB 65 score is 0, or the CURB 65 score is 1 in a patient who is more than 65 years old. You have to admit the patient to ward if their CURB 65 score is 1 or a score of 2 in a person more than 65 years, or if their saturation is less than 92%. Finally, an ICU admission is required if the CURB 65 score is 2 or 3 in a person more than 65 years, or if there's respiratory failure that requires mechanical ventilation, or if the patient is in sepsis with hypotension and shock, or any of these features like altered mental status, temperature that's less than 36 degrees Celsius, a leukocyte count that's less than 4000 per ml, and a platelet count less than 1 lakh. Now in this slide, I will be talking about further microbiological evaluation depending on the severity of the condition and where the patient is being admitted. So if the patient has a moderate or a severe pneumonia, meaning if they're either admitted to the ward or admitted to the ICU, certain further tests have to be done, like blood cultures, because there is a chance of bacteremia, sputum gram stain and culture, urine Legionella testing if there are other features, like if the patient is COPD or a smoker with a history of a cruise ship travel or a hotel stay, and PCR for influenza virus if it is during the influenza season, for example. Also, in intubated patients with suspicion for aspiration pneumonia, you could consider an endotracheal aspirate for culture in gram stain. That's because usually in people who are intubated, the chest X-ray more or less would show an infiltrate. So to really to rule out a pneumonia, you have to take an endotracheal aspirate and do the culture. Next, coming to treatment. Now, treatment, I've divided it based on their site of care. So if it's an outpatient management, empiric antibiotics targeting Streptococcus pneumoniae and atypical pathogens is what we use. So if the patient is healthy without any comorbidities, by comorbidities I mean those with chronic renal disease, chronic heart disease, diabetes mellitus, asplenia, or any kind of immunosuppression. If the patient is healthy without such comorbidities, we'll just go with monotherapy, either with amoxicillin or doxycycline or a macrolide. It's just one drug. But if the patient has comorbidities or if they have a history of previous antibiotic use, then we could consider a combination of amoxicillin clavulinate or a third generation cephalosporin plus a macrolide or doxycycline. Otherwise, again, you could consider monotherapy, but with a higher end antibiotic like a respiratory fluoroquinolone like levofloxacin, moxifloxacin. Now, suppose the patient has been admitted and the patient is in ward but not ICU. Again, you can use a combination option with amoxicillin clavulinate or third generation cephalosporin plus a macrolide or doxycycline. Again, if not combination, you can consider monotherapy with respiratory fluoroquinolone. If the patient has been admitted to ICU, then it has to only just be a combination of either amoxicillin clavulanate or a third generation cephalosporin plus a macrolide or doxycycline or a respiratory fluoroquinolone. So in an ICU patient, the only option is for a combination therapy. Now suppose there is a suspicion for Pseudomonas, then you will have to introduce an anti-pseudomonal antibiotic like a cephalosporin like cefepime or cefotaxime plus or ceftazidime plus macrolide or doxycycline or a respiratory fluoroquinolone. Now, what is the duration of treatment for pneumonia? Basically, the duration depends on the clinical response to treatment, and we generally treat until the patient is afebrile, clinically stable for at least 48 hours. Minimum duration of treatment is 5 days, and for a mild infection, we usually treat for 5 to 7 days. But if it's a severe infection or with comorbidities, we will treat for 7 to 10 days. Finally, it just depends on how the patient is responding to treatment. And follow-up imaging usually is not required unless you have a suspicion for an underlying lung malignancy, in which case we'll take a CT scan of the chest after about 4 to 8 weeks after the features of pneumonia has subsided on radiographic imaging. Now, suppose the patient does not resolve with antibiotics, what should you think of? So, this could be because of comorbidities that generally will make the patient take longer to resolve, or if it's a very severe pneumonia with bacteremia and sepsis, or if there's presence of loculated infection like any ABSCESS or empyema, that above antibiotic coverage would also require drainage. Then if there is any cause of bronchial obstruction like a tumor, this could cause post-obstructive recurrent pneumonia because of stagnation of secretions and bacterial colonization. It can lead to recurrent pneumonia. In this case, especially if it's a tumor, you have to take a chest CT. Now, there are certain pathogens which will not resolve with your usual antibiotics like Mycobacterium tuberculosis, non-tuberculous mycobacteria, fungi. These cause subacute or chronic pneumonia that fails to respond to empiric antibiotic therapy. So these are the few reasons why a patient would not respond or take longer to respond to treatment. Now, the next very closely knit topic with pneumonia is a parapneumonic effusion. Parapneumonic effusion, which I will be abbreviating as PPE later on in this video, is basically a pleural effusion adjacent to an area of pneumonia in the lung. Now, this can be divided as either uncomplicated or complicated or an empyema. An uncomplicated PPE is free-flowing, no loculations, and it is sterile. It's basically just the inflammatory response in the pleura causing increased fluid secretion. There is no bacteria in it. A complicated PPE occurs when bacteria translocates into the pleural fluid. So it's an effusion with bacterial translocation. And finally, if pus begins to develop in the pleural fluid, we call it empyema. Now we can divide this into 3 stages. Stage 1, that is uncomplicated PPE, is just the interstitial fluid moving into the pleural space. This is sterile, but it is still an exudate. It is free-flowing, just small to moderate in volume. And the features of the pleural fluid is usually pH that is greater than 7.2, glucose that is more than 60, white blood cell count less than 50,000 and LDH less than 1,000 units per liter. It's not a very worrisome picture, and if you take a gram stain in culture, you will just get a negative result because there is no bacteria. In these cases, we generally just have to treat with antibiotics and drainage is not required. But suppose it's a complicated PPE, which is stage 2, here there's bacterial invasion across the pleural membrane into the pleural fluid. The pleural fluid itself is moderate to large in quantity. It can be loculated with fibrinous depositions as well. And the pleural fluid characteristics is a little more worrisome. So it's acidic. pH is less than 7.2. Glucose is less than 60 because the bacteria is utilizing that glucose. White cell count is more than 50,000 because of the increased amount of inflammation. And LDH is more than 1000 units per liter. And in these cases, if you take a pleural fluid aspirate, the gram stain and the cultures may be positive. And if it is frank pus, then it is definitely, there's a very, very high chance that the cultures come out positive. And finally, the stage 3 is a stage of organization where there's deposition of fibrin and fibrinopurulent material that essentially covers the lung and encases the lung. And this can resolve like after about 6 months or more, but if it does not resolve, this encased lung leads to something called a trapped lung, where it's really hard to expand that lung. There's impaired lung expansion. Now, how do you evaluate pleural effusion in patients with pneumonia? The first step to do is get an ultrasound of the chest and try to characterize the pleural fluid. If you have characteristics of an uncomplicated effusion, like it's just minimal fluid, there are no loculations, it is freely flowing, and the patient does not have any severe symptoms, then there is no need for any thoracentesis. You can treat with antibiotics alone. There is no need for drainage. The only reason we would take pleural fluid is for a diagnostic characterization of the fluid, but you don't essentially have to therapeutically drain it. Just antibiotics will do. But on an ultrasound, if you see characteristics of complicated effusion, like it's a large to moderate amount of fluid collection, there are loculations, then you have to assess the type of fluid. For example, if there is pus, that essentially means that's empyema. You'll have to treat it with antibiotics and drainage. If there's no pus, it's mostly a complicated effusion which also requires treatment with antibiotics and drainage. And coming to the specificities of treatment, the most common cause of parapneumonic effusion is usually Streptococcus pneumoniae and Staph aureus. If it's an uncomplicated PP, as I've mentioned, just empiric antibiotic therapy is enough. You do not require a drainage. And after that, you need to do a radiographic monitoring, like with an X-ray, to ensure that the patient is responding to the antibiotic treatment and the effusion has started to reduce. If it's a complicated PPE or an empyema, you need both an antibiotic therapy and a drainage with a tube thoracostomy, and monitor with a chest X-ray or a CT in 24 hours, again to ensure that the effusion is resolving. So what are the specific antibiotics that we use? For an uncomplicated PPE, the antibiotics are the same as what we use for community acquired pneumonia, no need for drainage. If it's a complicated PPE, we need antibiotics and drainage. The antibiotics should cover Streptococcus pneumoniae, oral streptococcus, and anaerobic bacteria, because many cases can also be caused due to aspiration of oral flora. It is given as, initially it's given as an IV therapy with third generation cephalosporins like ceftriaxone or cefotaxime with metronidazole for the anaerobes. Or you could try a combination of a beta-lactam and beta-lactamase inhibitor like ampicillin-sulbactam. And if it is hospital acquired, you have to also cover for MRSA, gram-negative organisms like Pseudomonas and anaerobic bacteria, in which case you will give a combination of vancomycin for MRSA, metronidazole for anaerobes, and anti-pseudomonal cephalosporins like cefepime and ceftazidime. And coming to drainage, drainage is usually using chest tube thoracostomy. And immediately after drainage, the first thing to do is to get a radiographic assessment to make sure that the tube is correctly placed. And after that, follow it up with clinical and radiographic assessment to make sure the patient is improving. Finally, when can you discontinue this drainage? You can discontinue it if the volume falls less than 50 to 100 mLs per day. And on pleural imaging, you find that the size of the effusion is reducing well. You find there is a resolution of clinical symptoms in the patient. If all of these are there, you can discontinue drainage and discharge the patient on oral antibiotics and ask them to come back to review with a chest CT after 2 weeks to make sure the patient is improving. Now, suppose this antibiotics and drainage option does not work, there are certain other modalities. For example, intrapleural tissue plasminogen activator with the DNase. This is basically to break down all that fibrinopurulent material. And this is especially done in highly loculated effusions. And the next option is a video-assisted thoracic surgery to break down all those fibrinopurulent material. And finally, surgical decortication. This is like the final option in case of pleural fibrosis and thickening, leading to trapped lung that's not resolving and the patient is not able to breathe properly. In that case, you could go for surgery, that's decortication. So the therapy is initially, as I've mentioned, started as IV and then switched to oral regimen. Usually the duration of therapy for uncomplicated effusion is around 1 to 2 weeks. For complicated effusion, it's around 2 to 3 weeks or longer. Again, it depends on the patient's response. For empyema, it's going to be 4 to 6 weeks or longer. As I've mentioned, monitor radiographically to ensure that the patient is improving. But also keep in mind that complete radiographic resolution on the chest X-ray or CT would take weeks to months, and a residual pleural thickening can also last even longer than that. So you have to keep these points in mind before saying that the patient is not improving. The next topic I'll be talking about is lung abscess. So you can classify lung abscess into primary or secondary. Primary is an abscess that develops directly from an infection of the lung, like for example after aspiration pneumonia, and the lung does not have any predisposing structural problem in it. Secondary is development in a person with predisposing factors, like there's a bronchial obstruction due to tumor or due to hematogenous spread like a septic embolus from right-sided infective endocarditis, or in an immunocompromised state that has led to secondary lung abscess in the lung. Organisms involved in lung abscess, if it is because of aspiration, it is generally polymicrobial. It includes anaerobes like Peptostreptococcus, bacteroids, Fusobacterium, and also Streptococcus viridans, which is basically the oral flora. So certain predisposing factors for aspiration include alcoholism, patients who are in coma, patients who have some sort of neurological dysfunction leading to dysphagia, inability to swallow properly, patients with dental infections. So because these are all oral flora, you basically have a polymicrobial picture. It could be pyogenic causes like Staphylococcus aureus in post-influenza pneumonia that is also associated with pseudocysts. Klebsiella in alcoholics, and other causes like Pseudomonas and Streptococcus pyogenes. Certain non-bacterial causes to remember are fungi like Aspergillus, Histoplasma, Cryptococcus, Mycobacterium tuberculosis, parasites like Entamoeba histolytica and Paragonimus westermani. So a patient with lung abscess usually presents with a low-grade chronic or subacute fever with chills, night sweats, weight loss, anorexia, fatigue, very important, cough with a productive foul-smelling sputum, dyspnea, hemoptysis. And this is important. These symptoms are not acute. These occur over weeks to months. They have a subacute to chronic presentation. Evaluation for a patient with lung abscess includes microbiological evaluation like blood cultures. Sputum culture and gram stain can be used, but they're not very useful in clinical practice. Radiographic evaluation with a chest X-ray will show fluid-filled cavities with air fluid interface. That's very important. And CT is usually taken because it shows better anatomic details. Coming to treatment. So empiric antibiotic therapy is usually started in patients with lung abscess, and we'll use IV, ampicillin sulbactam or imipenem or meropenem. If the patient has a penicillin allergy, then you could consider clindamycin or fluoroquinolone. And you find that the patient is improving, that is clinically the white cell counts have reduced, then in these patients you can transition from IV to oral antibiotics based on their culture sensitivity, and totally you will be treating them for around 3 to 4 weeks. Now, in case of failure to improve, now this sort of improvement is not seen, then you could consider changing antibiotics based on the sensitivity results. You have to consider any resistant pathogens. You could consider some sort of underlying tumor that could be leading to the abscess, in which case you could take a CT scan. And if it does not improve after about 7 to 10 days, you would even have to consider drainage, about which I will be talking about. So that is when you have to intervene. So you have to start thinking about drainage either by percutaneous or transbronchial catheters, or even surgery in case it's a very large abscess, or if there's very large volume hemoptysis and the patient is not stable, and if there's persistence of fever and purulent sputum and clinical features for more than 7 to 10 days despite giving adequate antibiotics. These cases you can consider drainage or surgery. Apart from what I've mentioned, like if there is a tumor that you're suspecting, of course take a CT scan. And also this has to be done after you try other antibiotics based on the sensitivity or resistance of the pathogens. And some important points to remember here is that fever will generally take 7 to 10 days to improve, and the abscess cavity on X-ray or CT would take around 3 to 7 weeks to really close off. So these have to be considered because before you say that the patient is not improving. Now our final topic today is aspiration pneumonia, and before I talk about aspiration pneumonia, I would like to mention a few terms. For example, first is chemical pneumonitis. Now this is essentially aspiration of acidic gastric fluid into the lungs, leading to inflammation in the lungs. This usually happens after a surgery, and these happen quite fast, quite acutely within a few hours after aspiration. On the other hand, aspiration pneumonia is the aspiration of infectious organisms like bacteria, leading to inoculation and active infection of the bacteria in the lungs, and these take a longer time to manifest, like around 48 to 72 hours after a patient is intubated, for example. Now, the risk factors for aspiration pneumonia include reduced consciousness like coma, or if the patient is on sedatives, these essentially impair the cough reflex. Patients who are alcoholics, neurologic deficits leading to dysphagia, like for example in stroke where swallowing is not really coordinated, presence of endotracheal tubes or nasogastric tubes, which basically cause anatomic disturbances, recurrent vomiting leading to recurrent aspiration, certain upper GI disorders like reflux disease, and also poor dental hygiene, because the concept here now is that people generally have small volume microaspirates which are quite small that do not lead to an aspiration pneumonia. But if the dental hygiene is very poor, the bacterial inoculum that is aspirated is quite large, and that high inoculum volume is what predisposes to aspiration pneumonia. So coming to microbiology, that's mostly anaerobes like Peptostreptococcus, Fusobacterium bacteroides, and aerobic bacteria. It's usually polymicrobial. The severity of this pneumonia depends on the size of the inoculum, the pathogenicity and virulence of the bacteria causing it, and host defenses if they're impaired, for example, immunocompromised patients. Patients with aspiration pneumonia come with indolent fever, that's a long-standing chronic type of fever. They need not have chills and rigors. They have cough, purulent sputum, and dyspnea, and they have some sort of predisposing condition that I talked about before. The treatment can be divided as outpatient management with amoxicillin clavulanic acid, which covers the polymicrobial spectrum. If the patient is inpatient, but not, that is in the ward, not in ICU, then ampicillin sulbactam. And for ICU patients, a much higher grade antibiotic has to be used, like piperacillin tazobactam or meropenem, because you essentially have to also consider treatment for Pseudomonas. Now, certain methods to prevent aspiration pneumonia would be: first is to keep the patient in a semi-recumbent or a head-end elevated position to prevent aspiration and proper swallowing. You have to evaluate the swallowing mechanics in patients with neurologic dysfunction like stroke to see if there is some abnormality in their swallowing. Third is to provide enteral feeding, like instead of prolonged nasogastric tube, direct enteral feeding can be considered. Then changing the composition of feeds, like thickened feeds that can prevent aspiration while swallowing. And of course, to maintain oral hygiene, and this because this reduces the inoculum volume of the microaspirate. So that is about ways to prevent aspiration pneumonia, and that would be the end of this video. Thank you, and I hope you enjoyed it.